an assistant professor of neurology from the Yale School of Medicine, stroke director from Connecticut healthcare system. He has done his MBBS from India, PhD from Glasgow, UK, neurology residency from IANCON School of Medicine and Mount Sinai, New York, fellowship in gastroenterology. Currently, he is an assistant professor at the Department of Neurology, Yale School of Medicine. Expertise is stroke and cerebrovascular disorders. He is a fellow from Royal College of Physicians, fellow from American Heart Association, with over 60 peer-reviewed publications. Over to you, Dr. Shah, for your book.
Thank you so much for this kind introduction. I'm from here. I was born not far from here, so even though I live in the United States, I'm from here. And really, thank you so much for giving me this opportunity to be here amongst you and share some thoughts on post-stroke epilepsy work that I've been doing. It's really a great privilege, and I feel very humbled to be here in my own hometown and sharing some thoughts with all of you. So thank you. So I'm going to talk about post-stroke epilepsy. Post-stroke epilepsy, it refers to the late seizures, the seizures that happen after 7 days of stroke. Those that happen within the first 7 days are called early seizures. And early seizures contribute to the increased risk of late seizures, but by themselves do not lead to the definition of post-stroke epilepsy. And why is this important? Why study post-stroke epilepsy? So there is a significant emphasis in understanding the mechanism of epileptic genesis, the mechanisms, the biological pathways through which the late seizures happen in human beings. And because I'm a stroke doctor, I felt that stroke leads to discrete lesions in the brain in the human beings, and therefore a great population to investigate the epileptogenic pathways. Cerebrovascular disease accounts for almost 50% of late onset epilepsy, seizures that happen in age group above 65. And as you know, there are two peaks regarding the increased risk of seizures in human beings. One is, of course, the pediatric age group, and then later on in the older age group. So this is definitely a big burden of disease in which we should be putting in efforts. For a long time, when I started my journey in stroke neurology, I used to think, why not develop data for our own population, our own countrymen? A country of 1.4 billion people with extremely talented neurologists, great PhD scholars, why not generate our own data? I did look at some of the questions related to appropriate dosing, and again here, in this context, in the context of post-stroke epilepsy, I guess a huge burden of disease. 10 million people in India suffer from epilepsy. The prevalence is very high in rural areas, and seizures are associated with psychological cost, stigma. Stigma is a big problem. So it's very important for us as a country to understand the mechanism of epileptogenesis. I'm a stroke doctor. I'm thinking about post-stroke epilepsy. Some of you may be doing neurocystic sarcosis, some other kind of neuropathology, and of course, understanding the mechanism of epileptogenesis, and then try to discover ways to inhibit that process so that we can prevent seizures from happening in our population. The stroke doctor is also interested in understanding and preventing the adverse drug reactions that may potentially complicate outcomes in stroke population. So when we started out, when I started out looking at post-stroke epilepsy almost 5 years ago, I looked at data from across the world along with my colleagues, and we found that there's significant interest across the globe. And stroke being a major health problem worldwide, it would make sense to investigate it, but the epidemiological data indicates that the risk is 5%, 8%, 10%. So in certain ways, it's a rare pathology. But to tackle that, I matched up with one of my colleagues, Patrick Kwan, who's a professor of neurology and epileptologist in Monash University, and many others, including colleagues from here in our own country, to understand ways to prevent epileptogenesis, to generate data, to build some collaborative efforts. This is a database that we have been working on, and interested colleagues are welcome to join us in this effort. There's a huge impetus on Make in India. Why not do it in the research and clinical neurology research? We have large patient population. I hear that our colleagues see so many patients here. We have many young, enthusiastic trainees. We have many candidates doing great MDs and PhD theses. Why not build the infrastructure and collect good quality data and build an infrastructure to jointly tackle the problem of post-stroke epileptogenesis or anything similar with other neurological problems. Many of these colleagues, postdocs and PhDs have worked with me in the United States and really helped me succeed in my research agenda. For example, this systematic review, in which we were interested in understanding the common pathways, common mechanism by which one could explain the mechanism of epileptogenesis. An opportunity for us to work together. So whenever we start a new line of investigation, one of the first questions that funding bodies, policymakers ask is, why is this important? We looked at outcomes in patients with post-stroke seizures, and we were able to show the obvious. We demonstrated that there is increased mortality risk in the patients with post-stroke seizures. There is poor functional outcome, ranking 3 to 6, increased 2 times greater odds, disability, and greater risk of cognitive problems. Not surprising, but we need these data to demonstrate that the question is important. And then it's critical for us to unravel the relationship of this highly clinical and high research priority research question. We need trials. What are the risk factors? Age, stroke types, hemorrhagic stroke, for example, more likely to have post-stroke epilepsy, cortical involvement. If somebody had early seizures within the first 7 days, that person is more likely to have a greater odds of having late seizures. Family history, genetics. Clinical manifestations. So focal seizures, more likely to happen, but many individuals can have behavioral manifestations from stroke-related late seizures. I vividly remember one patient I saw with Dr. Hastak, who was one of my initial mentors in Mumbai, who offered TPA to this gentleman, and this person who was unable to move his hand texted him with the same hand saying that, hey, now I'm able to move my hand. Fast forward several months later, he starts having this bad hallucination and delusion. When he's crossing the streets, he feels people are looking at him, staring, making unnecessary comments. Seizures, put on anti-seizure medication. I don't know how I got interested. There's no direct link between what I did several years ago versus, but this is definitely an important problem that we encounter in our communities. Because number one, stigma is associated. Family lives get affected. Husband-wife relationships get involved. Diagnostic workup. Motor seizures, very easy to diagnose. Non-motor seizures, EEGs provides supporting data, definite post-stroke epilepsy. No EEG data, but some imaging data, diffusion-weighted lesions, for instance, ESL, SPECT. Some of these approaches can definitely help us stratify patients into probable post-stroke epilepsy versus definite post-stroke epilepsy. My colleagues and I, including colleagues from here, Varanasi Vishwavidyalaya, did a tremendous job at doing this massive systematic review and meta-analysis. Shubham Mishra is one of the postdocs who I recruited from All India Institute of Medical Sciences a couple of years ago. And he was instrumental in doing this work, along with Priya Dev, who is a who graduated with a PhD degree from BHU, and Abhishek Pathak being her mentor. And we demonstrated that, so two things here. One of the missions that I've had is to encourage young persons interested in neurology research, promote them, and also teach them the art of understanding the evidence that is out there. To become a good clinician, we need to be able to comprehend the ways the guidelines are framed. So these colleagues in this group, they conducted systematic review, did the network meta-analysis, applied the grade methodology to really grade the level of evidence. So it's just not the data, the results that we're looking at, but also the approach, the methodology, because that becomes very critical in these times when we are flooded with large amount of data on PubMed on many critical questions. So we were able to demonstrate that heparin, lamictal may be safe and tolerable anti-seizure medications for this patient population. But I started out with the goal of preventing post-stroke epileptogenesis. I won't take much of your time describing the pathophysiology, but would like to highlight this cartoon here. So on the x-axis you see the time since the injury, the stroke in this context. And on the y-axis you see the seizure threshold. And then A, B, C, D, these are the insults that you're seeing. And as you see, with increasing insult and continuous epileptogenic anomaly, the seizure threshold, the green line, it declines gradually. And once it crosses the red line, goes below it, the person starts having seizures. If there is a progression of the disease, then the seizure threshold keeps declining and the person is at a greater and greater risk of having late seizures. And in the case of remission, that green line goes up and he's no longer having the seizures. And the goal is, in the setting of primary prevention, is to prevent somebody from having late seizures. And therefore you want to offer intervention early on after having discovered some biomarker of epileptogenesis. Select those patients, give them information, and hopefully the patient never develops late seizures and doesn't suffer from the complications that come from it. So we need biomarkers. Biomarkers are needed because, as I said, number one, a relatively rare disease. Even though stroke is very common, the risk of late seizures is 5%, 10% in that range. So you want to be able to predict the development of epilepsy condition. You want to be able to enrich the patient population. So biomarkers are needed. You want to be able to understand if there is a progression of disease. So if there is a progression of epileptogenic process, you want to be able to discover that. I was highlighting this biomarker work earlier on. We looked at the published data from almost 22 studies and did some meta-analysis and enrichment analysis trying to detect the biomarkers which have already been reported in the published literature. And we noted that we could not recommend any specific biomarker yet because of the poor quality of the studies. Disparate time points when the data were collected, variable definition of post-stroke seizures or post-stroke epilepsy, lack of validation data. So there are methodological problems. Again, there's an opportunity for collaborative research to tackle the methodological heterogeneity, bias in included studies, lack of validation. And we see these data presented, the biomarker data presented at many meetings very often. And we need to know that any data we generate needs to be acceptable to the regulatory bodies. And therefore, we need to be familiar with the FDA, the Food and Drug Administration, or the local regulatory bodies here, so that the research that we do in terms of biomarker discovery and validation, that is valid and acceptable to the regulatory bodies, so that that gets translated into the drug development later on. Trials are expensive, and to reduce the cost of trial execution, we need ways to enrich the patient population in the trial such that we're selecting a more responsive patient population. There are some scoring methods that have been reported. For example, select score. which includes some of these items as you can see on the slides, to a Nash-Torr scale, a kind of early seizures, particle involvement, blah, blah, blah. And as the score is higher and higher, the risk of having, so this is an approach which can be used to enrich the patient population. We did some work to demonstrate whether the polygenic risk scores may be useful in selecting high-risk population. And we did design a model which could potentially help, but this needs validation. It lacks the registry data, it lacks the data from the other rating ethnicities. So there is a genetic factor as well, and therefore it again becomes very critical for us in India to use our data for drug development activities. I'm running short of time, so I will move on to the conclusive slides, wherein it highlights the need for a better selection approach and trial enrichment strategies. And with this, I will thank you for your attention.